All right, good morning again. So, today's lecture is on the right heart, and what we're going to do is look at the right ventricular size and function, the right atrial size, the tricuspid valve, pulmonic valve, and the inferior vena cava. So, all the stuff that's on the right side of the heart. In former years, we would have neglected uh, these structures, but over time, we have realized that they're very, very important for the proper functioning of the heart. So instead of discussing them separately, we discuss them together. And those of you who do studies, know that we commonly measure stuff related to the right side of the heart. Um, so, all right. So just going over the function of the right ventricle. We know that the right ventricle receives blood from the right atrium through the tricuspid valve. That's a normal function of the right ventricle. So it's a receptacle. It's it's a reservoir in some respect, but it also contracts. Um, so we can look at some of the disease that affects the right ventricle. Because as we said, the right ventricle is supposed to receive blood from the right atrium. But if it's not functioning properly, then you can run into problem. So some of the disease that can affect the right ventricle is RV infarct. So a heart attack involving the right ventricle can affect the pumping function of the right ventricle. Remember that just like the left ventricle, when the right ventricle fills with blood in diastole, it contracts to pump blood across the pulmonic valve into the pulmonary trunk and into the main pulmonary arteries going to the lungs. So if it's not contracting, if it's not pumping properly, then it's going to affect the normal functioning of the heart. So a heart attack involving the right ventricle can affect the pumping action of the right ventricle. So usually when you have an inferior wall heart attack, you should look for a RV heart attack. Okay, so 1/3 of all patients who have an inferior wall heart attack will have a RV heart attack. And remember, we call heart attack infarcts. So you should look for it. Cardiomyopathy. When we say cardiomyopathy, it is heart muscle disease. And what we mean is that the heart muscle is weak. So you can have a cardiomyopathy involving the right ventricle, or you can have a cardiomyopathy which involves the whole heart, which includes the right ventricle. Pulmonary hypertension. So that means there is resistance to blood flowing across into the pulmonary circuit. So that over time, that can cause the right ventricle to hypertrophy, that thickens, and it can affect the function. It can reduce the systolic function. And then we talk about left to right shunt. So if you have, say, atrial septal defect or a ventricular septal defect, and blood is flowing from the left side of the heart into the right side of the heart, over time you get what we call a volume overload. So the right side of the heart, the volume on the right side of the heart increase. Once you have increase in the volume on the right side of the heart, you're going to have increased blood flow into the pulmonary circuit. You'll develop pulmonary hypertension, and then it can affect, all those things can affect the proper function of the right ventricle. And arrhythmogenic RV dysplasia. So whenever you see this, arrhythmogenic RV dysplasia, what this means is the right ventricular muscle is replaced by fibrofatty tissue. So fibrofatty tissue cannot contract. So therefore, you're going to lose the contractile function of the right ventricle. So that's what this means. Arrhythmogenic RV dysplasia. So RV dysplasia is basically when the right ventricular muscle is replaced by fibrofatty tissue. And the reason why we say arrhythmogenic is because those patients are now prone to abnormal rhythm. They're prone to developing ventricular tachycardia and ventricular fibrillation, and that can kill patients. Okay. So the echo finding that best differentiate the right ventricle from the left ventricle, and we'll go over this over and over and over. And of course, you're going to get it in some form in your tests. So you have to know what distinguish the right ventricle from the left ventricle, because when you're doing an echo, remember the echoes do not come labeled. You know, if you have a congenital defect, you have to figure out what is what. And the best way to start is to distinguish between the right side of the heart and the left side of the heart. Because if you can do that, then you can identify the tricuspid valve. And we always say that the tricuspid valve is identified by being the lowest AV valve in the ventricle. So the more apical insertion of the septal leaflet of the tricuspid valve relative to the mitral valve, all we're saying is that the tricuspid valve is lower in the ventricle than the mitral valve. And once you see that, then that side is the right side, or that is a tricuspid valve. The best thing to say is that's a tricuspid valve. Also, the presence of a moderator band. Okay, so the moderator band is usually in the right ventricle. So you should try and identify that. So one of the ways to identify the moderator band is to your apical 5-chamber view. So if you do your apical view and then you move into the apical 5-chamber view, you can see the moderator band lower down into the right ventricle. Also, the number of papillary muscles. Remember, on the left side, you usually have only 2 papillary muscles, where on the right side, the right ventricle, you will have 3 or sometimes more papillary muscles. So these are the structures and features that distinguish the right ventricle from the left ventricle, and you have to know them. All right, so the presence of 3 or more papillary muscles, the trileaflet configuration of the tricuspid valve with septally papillary muscles attachment. So, and also you have to know how to identify the different leaflets of the tricuspid valve. So remember, you have 3 leaflets in the tricuspid valve. You have a septal, you have an anterior, and a posterior. So you have to know which is which, because it's fair game for them to ask you, which one, which is which. And again, the presence of coarse trabeculations in the right ventricle. So the right ventricle tends to have more trabeculations than the left ventricle. Okay, and then the tricuspid valve of 3 leaflets. So you also have to know about the dimensions in the right ventricle, and so these are measurements. You have to know what are the normal measurements in the right ventricle, and when you're going to do measurements in the right ventricle, it should be a RV focus view. So you get your apical 4-chamber view, but you're going to modify it a little bit to focus more on the right ventricle. Okay, and then these are the measurements that you you're gonna you're gonna do. You can do this long axis. Okay, so you draw a plane. This is a tricuspid valve plane. So you make sure you get that, and then perpendicular to that, you drop uh, a line straight up to the apex of the RV. Okay, so you talk about the well, so you do that, and then you also make these measurements. So the you're going to have the what we call the the basal and mid cavitary. So you're going to make this RVD1. So this is at the base of the tricuspid valve, and you're going to do this measurement. Okay, the upper limit of this is 4.2. So anything above 4.2 is means a dilated uh, right ventricle. So when in the actual echo, this is how it's done. It's a RV focus view, tricuspid valve plane, okay, from the lateral to the septal, and you measure it, okay. So that's the basal measurement, and then the mid cavitary measurement. So in the mid cavity, you drop um, a perpendicular to this line right there, okay? And then the upper limit of this, I think, is 3.5. So you have to remember these values because they'll ask you. And then this RVD3, which is the longitudinal dimension. So so you have these are minor dimensions at the basal and the mid cavitary level. So this is the basal measurement, okay, minor dimension, mid cavitary, and then this is your longitudinal dimension. The upper limit of this is 8.5. So you have to get greater than 8.5 to say you have RV enlargement. Okay, so again, it's a RV focus view, okay, and you'll get your tricuspid valve plane, and then perpendicular to that, you go straight up to the apex of the heart. Then you have so this is the longitudinal dimension, this is the minor dimension at the base, and the mid cavitary. So those are measurements that they expect you to do. All right, so again, measurement at end diastole. So these measurements are measured at end diastole when the heart is fully uh, uh, dilated and filled with blood. Okay, so and again, right ventricular focus apical four-chamber view. So this is not a straightforward apical four-chamber view; it's an RV focus. And then at the base, the minor dimension at the base, anything greater than 4.2, meaning the RV is dilated. The mid-cavitary level, anything greater than 3.5, indicates RV dilatation. And then the longitudinal dimension, greater than or equal to 8.6, all right, indicates RV enlargement. So what you do, you have to memorize it. So that is what you have to do, it over and over and over and over, and then measure it. And once you do that, then it will become a part of you. You don't have to memorize it anymore. All right. So there are other measurements that you're going to do in the right ventricle, because you have to determine if the right ventricle is dilated, yes or no. We talk about the outflow tract, the right ventricle outflow tract, and there are three measurements that you should do to determine if there is right ventricular outflow tract dilatation and hence RV dilatation. So you can do the proximal measurement. So your your parasternal long axis view, and you measure it again. This is in diastole. So so the aortic valve is closed, the mitral valve is just about to open. So this is how it's done. The RV proximal measurements, or you can do it in the short axis view from the aortic valve to the RV wall. Okay, you can also do the distal measurement. So the distal measurement, of course, it's the short axis view, but you're focusing on the right ventral flow tract. Okay, and again, you have to know the measurements for these. Okay, so you can do your right ventricular flow tract measurements at the proximal. So the proximal can be in the parasternal lung, right there, short axis right there. Okay, or at the distal or pulmonic valve, which is done also in the short axis. But this is if you look closely at this is a RV focused view, and you should practice these views. So when you get your short axis at the level of the aorta, you just modify the view to show more of the right ventricular flow tract. So you should practice these views, okay? And then this is the distal measurement, just right at the pulmonic valve. And then if you're going to measure the main pulmonary PA dimension, it's down there. So it's a little bit different. So the measurements for these, so the right ventricular flow tract, if the distal measurement should be less than 2.7. So if you get more than 2.7, it indicates that you have dilatation of the distal RV. I mean the distal right ventricular flow tract. And then for the proximal measurements, it should be less than 3.3. Should be less than 3.3. Just all right, sorry about that. So so you have to know these measurements. All right, so it's very important to know these measurements. So again, the distal RV is measured at the end diastole in left parasternal short axis at the insertion of the pulmonic valve. So you have to know where that measurement is done. And again, if it's more than 2.7, it indicates distal RVOT dilatation. And then if you're going to do the proximal measurement, if it's greater than 3.3, it indicates dilatation of the proximal RVOT. Okay? So know where you're supposed to measure and be familiar with the numbers that goes along with it. All right, so we talk about the dimensions in the RV, how to measure them, and what makes it an enlarged or a dilated RV. Now we're going to go to RV thickness, and they commonly bring this as well. You have to know where to measure the RV wall. So you should measure RV thickness, especially if there's evidence of thickening of the RV wall. If the patient have pulmonic stenosis, you should measure the thickness of the RV wall. So you can measure the thickness of the RV wall. You can measure it in the parasternal long axis view or the subcostal view. Okay, so this is a subcostal view right here. And of course, the right side of the heart is right against the liver, and the RV wall is right here. Okay, so you can zoom it up. You should zoom it up and then measure it. Anything greater than 5 millimeters, or 0.5 centimeters suggests that there's RV thickening. Or you can use your M mode. Okay, so remember, when you do your M mode, you can line your cursor and look at the structures that you're crossing, and then where you see the RV wall, again you zoom it and measure it. Okay, remember the measurement of the RV wall is done in diastole. Okay, so you have to know what phase of the cardiac cycle you do these measurements. So the RV wall dimensions and the RV wall thickening is done in diastole, end diastole. And again, you have to zoom it. When you zoom it, you reduce the error. All right. So Measurement at end diastole, the right ventricular wall thickness, subcostal view, two-dimensional image of the right ventricular wall. You zoom it, remember, and then the right ventricular wall thickness is indicated by the arrow. M mode image corresponds to the arrow. So again, when you're doing M mode, it should always be two-dimensional directed, so you get an accurate measurement. All right, so the RV wall thickness is measured in end diastole subcostal view or with the left parasternal view. It is regarded as being thickened if it's greater than 0.5 centimeters or 5 millimeters. And then you usually get IV hypertrophy. So when it's thickened, when any muscle is thickened, we say it's hypertrophed or it's hypertrophy. Okay, when the muscle is thickened, we say it's hypertrophic, and you get it mainly in hypertrophic cardiomyopathy. I know there's pulmonary hypertension there, but it's mainly pulmonary stenosis. So it's mainly pulmonary stenosis, and then infiltrative disease. That means some substance is getting into the muscle, so that can also cause thickening. And the prototypic infiltrative disease is amyloidosis. Okay. All right. So we talk about RV wall thickening, RV dilatation. You know, the different methods. And how to measure it. We talk about the upper limits of measurement. Now we're going to go to RV systolic function. So just like the left ventricle, the RV has a systolic function when it contracts and a diastolic function when it relaxes and fills with blood. So we're going to look at the RV systolic function because remember, it's important for the heart to have a normal RV systolic function so that the right ventricle can pump blood across the pulmonary valve into the pulmonary trunk and then into the main pulmonary arteries, going to the lungs so the blood can be oxygenated and get back to the left side of the heart. So RV function is very important. And when we started the lecture, we outlined some of the things that can affect RV function. RV infarct, a heart attack involving the RV wall. We talk about the arrhythmogenic RV dysplasia. We talk about cardiomyopathy. So those are some of the conditions that can affect the function. Pulmonary hypertension over time can also affect the function of the right ventricular wall, the function of the right ventricle. So it's important to determine the systolic function of the RV, how well the RV is pumping, just like the left ventricle. So RV systolic function can be affected by primary right-sided heart disease. What we mean by that is that if you have a disease that just affects the right side, the right ventricle itself, and one of those diseases is the arrhythmogenic RV dysplasia. Remember what we said? RV dysplasia means that the right ventricular muscle is replaced by fibrofatty tissue. So the right ventricular muscle is replaced by fibrofatty tissue. Fibrofatty tissue cannot contract. Fat doesn't contract. And the right ventricle is going to be what we say arrhythmogenic. It's prone to developing ventricular tachycardia and ventricular fibrillation. Okay, so that would be a disease that affects primarily the right side of the heart. And there are others. And then you have secondary to left-sided cardiomyopathy. So when you have disease affecting the left ventricle, you name it, any disease that affects the left ventricle, it's gonna put pressure all the way back into the pulmonary circuit, which will eventually affect the right side of the heart. So the most common cause for right ventricular dysfunction is left ventricular dysfunction, because we know that the left ventricle, commonly you have cardiomyopathy, you have heart attacks, you have, you know, hypertrophic cardiomyopathy. So anything that affects the left side of the heart eventually going to increase the pulmonary pressures. Okay, that pulmonary pressure is going to put an additional strain on the right ventricle, and eventually the right ventricle will fail. So that's why we say, that's what when we say that the most common cause of right ventricular dysfunction is left ventricular dysfunction. That's what we mean. And then valvular heart disease. So, you know, you can have disease of the pulmonary valve. You can have pulmonary stenosis, pulmonary regurgitation. You can have aortic stenosis, aortic regurgitation, and that over time will affect the function of the right ventricle. So the function of the right ventricle is very important, and we can measure the function of the right ventricle. We can assess RV systolic function using a number of different studies, different measurements. So when we talk about RV systolic function, we can just look at the RV and determine, is it contracting well, yes or no? And so that's a visual assessment. That's qualitative. It's not quantitative. So you can just look at the RV and say, yes, it's contracting very well because I see it's moving up and down or coming in. Okay, so qualitative or visual assessment. And then quantitative, that means you're doing some measurements to determine if the measurements are normal, yes or no. So quantitative measurements. And one of those quantitative measurements is RIMP. Okay, we'll go over this. RIMP, right ventricular index of myocardial performance. Okay, RIMP, right ventricular index of myocardial performance. We'll go over this. Okay, so we don't commonly, well, in large tertiary institution where you have a lot of patients with problem with the right side of the heart, they will do RIMP. We don't routinely do this measurement, but it's fair game in exams, so we can test you on it. Also, fractional area change. This is change. FAC. So this is two-dimensional RV fractional area change. So it is just, this is really simple. It is doing the RV area in diastole, the RV area in systole, and it is done just like you would do ejection fraction, but it's an area change. So it would be the RV area in diastole minus the RV area in systole divided by the RV area in diastole, and that is what we call the fractional area change. So these are the other stuff that you guys are more familiar with. You can do your systolic velocity of the RV, and this is what we call the tissue Doppler imaging of the tricuspid lateral annular velocity. So what you do, you get your apical four-chamber view, you get the lateral tricuspid annular plane, and you put your cursor right at the lateral. So you have to be careful. It's supposed to be at the lateral tricuspid annular plane, and then you just press your tissue Doppler button, and you want to see the systolic velocity. So in systole, that lateral annulus is going to have a certain speed, and that's what you're measuring. Below a certain speed, it suggests that the RV systolic function is reduced. Okay? TAPSE, so all of you guys are familiar with TAPSE, which is tricuspid annular plane systolic excursion. TAPSE is just the longitudinal displacement of that same tricuspid annular plane. You want to see how much it moves up, how much it moves up. So it's supposed to move up a certain dimension, and that's what we call TAPSE. It is tricuspid annular plane systolic excursions, how much it moves up. So what you do in your apical four-chamber view, you identify the tricuspid, the lateral tricuspid area. You put your cursor there, but instead of pressing TW, instead of pressing your tissue Doppler, you're gonna press your M mode. So it's an M mode measurement. TAPSE is an M mode measurement. Remember, when one of the most accurate means of measuring displacement is using the M mode. Okay, so it's an M mode measurement. Okay, TAPSE, tricuspid annular plane systolic excursion. You can also do RV, 2D RV ejection fraction. It's best if you're doing a three-dimensional echo. So it's not as accurate with the two-dimensional echo. So if you're doing three-dimensional echo, then the RV ejection fraction is fairly accurate. Three-dimensional echo is very good for volume assessment. So, and that is why. And then longitudinal strain and strain rate. So when we get to this topic, you'll have a much better understanding of what strain and strain rate is. But strain and strain rate is basically a change in length or the rate of change in length of the muscle. That's what you're measuring. And that is a very accurate assessment of the function, not only of RV function, but LV function. So the strain is the change in length. So you know when the heart contracts, it moves from a certain length to a shorter length. So especially in the longitudinal plane, so that would be a negative change. And then when in diastole, it lengthens. And then you can measure the rate of change in the length, and that's what we call strain rate. But when we do this topic, you'll get a much better understanding of that. So RIMP. So you have to know the definition of RIMP. And so we have RIMP and we have LIMP, but we're not going to do LIMP now. I think we do LIMP so we'll do LIMP tomorrow, as a matter of fact, when we finish up coronary artery disease. So RIMP stands for right ventricular index of myocardial performance. The other name for that is the TIE index. The TIE index, okay? So the definition for RIMP is it is from the tricuspid valve opening to the tricuspid valve closing minus the ejection fraction, minus the ejection time, okay, divided by the ejection time. So that's a definition for it. Okay, so the definition is right here. So I'm going to fully explain that. So myocardial performance index, tricuspid valve opening to tricuspid valve closing, minus the ejection time over the ejection time. So what we mean by that, so you have to understand what we mean by that. So this is the Doppler across the tricuspid valve. So, you'll have your E velocity and your A velocity, okay, suggesting tricuspid valve opening. Remember, the tricuspid valve opens in diastole. Tricuspid valve opens in diastole, just like the mitral valve. And then the tricuspid valve close at the end of systole, and then it opens again, okay? So these Doppler signals suggest tricuspid valve opening, okay? But when the tricuspid valve opens, then it closes, and then this is your systolic period, okay? And then the tricuspid valve opens again, okay? So remember, when the tricuspid valve closes, just like the mitral valve, when it closes, you're going into systole, but there's a period where you call the IVCT. Okay, so from this tricuspid valve closure to when you have ejection, this is what we call IVCT, isovolumic contraction time. Okay, so this little period right here from there to there is your tricuspid valve, sorry, this period from tricuspid valve closure to ejection is the IVCT, isovolumic contraction time. Then you have ejection across the pulmonic valve, okay? And then the pulmonic valve close, okay? The pulmonic valve close, now you're going into diastole, but before the tricuspid valve opens, you have your IVRT, isovolumic relaxation time. Then the tricuspid valve opens, and then you'll have blood flowing across the tricuspid valve. So tricuspid valve opening, tricuspid valve opening. The definition of MPI is from the tricuspid valve closure to tricuspid valve opening minus this ejection time, okay, divided by the ejection time. Okay, again, this little period from there to there is IVCT, from here to there is IVRT. If you subtract ejection time from tricuspid valve closure to tricuspid valve opening, you're going to be left with IVCT plus IVRT. So this tricuspid valve closure to tricuspid valve opening. So this TCO means tricuspid valve closure, tricuspid valve opening. So from tricuspid valve closure to tricuspid valve opening, okay, this period right here includes IVCT, ejection time, IVRT. So if you subtract, remember the formula, if you subtract ejection time from this, you're going to be left with IVCT plus IVRT. So this tricuspid valve closure opening minus ejection time just equal to IVCT plus IVRT, and then the formula you divide it by the ejection time. And they will probably give you these measurements, okay? They'll give you these measurements. The TI index. So simplifying the TI index, it's IVCT plus IVRT divided by the ejection time. With systolic dysfunction, you can get prolongation of the IVCT and shortening of the ejection time. So the RIMP increases. So with systolic dysfunction, the RIMP is usually greater than 0.4. So when you put in all your stuff, it will be greater than 0.4. Okay. Again, IVCT, isovolumic contraction time, IVRT, isovolumic relaxation time, ejection time. So your ejection time, you're gonna get your ejection time by putting your Doppler signal across the right ventricular flow tract. And then when you get the flow across the right ventricular flow tract, the ejection time is from the onset of ejection to the end of ejection. That's ejection time. So these are relatively simple measurements if you practice them. So the important thing is to know the definition of RIMP. As I say, it's not a routine measurement. If you work in a large institution that sees a lot of congenitals and stuff like that, then they use it. It's mainly, for the exams. You need to have a basic understanding of RIM for the exam. All right, so we talk about the fractional area change, and that's another mean of assessing RV systolic function. So it's an area measurement. It's a fractional area. So it's an area change. It's a change in the area. So it's the end diastolic area minus the end systolic area divided by the end diastolic area, and it should be greater than 35%. Okay? So it should be greater than 35%. If it's less than 35%, then it suggests RV systolic dysfunction. So what you're going to do is trace the RV endocardial border from the apical four-chamber view in diastole and systole. Okay, so this is how it's done. All right, so you remember it's RV we're talking about. So you trace the endocardial border in diastole, RV, and then you trace the endocardial border in systole. You're going to minus from the end diastolic dimension, the end systolic, and then divide it by the end diastolic. So in this, you can see the fractional area change here is 60%. That's normal. In this one, you do the same thing, endocardial border in end diastole, the endocardial border in end systole. You subtract the end systolic dimension from the end diastolic dimension divided by the end diastolic dimension, 40%. Once it's greater than 35%, it's normal. And then in this one, you can see it's 20%. You do the same thing. You trace the endocardial border in the RV in end diastole. You trace the endocardial border of the RV end systole. You subtract ES from ED and divide it by ED, and it's 20%. So anything less than 35% suggests RV systolic dysfunction. So we spoke about RIMP. We talk about fractional area change, and then all right, so we're not going to look at this table. This table look at a number of stuff that you can use, fractional area change. So remember, if you're doing ejection fraction, it's best to use 3D echo. We still have to discuss TAPSE. So TAPSE, again, the definition of TAPSE is tricuspid annular plane systolic excursion. How much that tricuspid annular plane moves up in systole. It's supposed to move a certain distance, and it's an M-mode measurement. So you're going to measure the distance of systolic excursion of the RV annular segment along its longitudinal plane, up and down, up and down. It's an M-mode measurement. You're going to use apical four-chamber view, and you're going to place the M-mode cursor at the lateral tricuspid annulus. Some people I see place it in the right atrium, right atrial wall. Some people, be careful. Make sure you place it where it's supposed to be placed, and it should be greater than 15 millimeters. It should be greater, the TAPSE should be greater than 15 millimeters. If TAPSE is less than 16 millimeters, it's abnormal. It suggests RV systolic dysfunction. Again, if TAPSE is less than 16 millimeters, it suggests RV systolic dysfunction. Again, it's supposed to move up a certain distance. If it's not moving at a certain distance, it suggests that the RV systolic function is reduced. The RV is a little bit different from the LV in that most of the RV, when it contracts, it moves up and down. So the tricuspid annular plane moves up to the apex. So that's how the RV contracts. That's the main mechanism for RV contraction, as opposed, which is slightly different from the LV. So that is why using TAPSE is a very accurate means of assessing the function. Just give me 1 second. So TAPSE is a very accurate way to assess RV systolic function, because the RV typically contract in the longitudinal plane. The base moves up to the apex. So, TAPSE is very accurate. So what you do is your apical 4-chamber view. You can do RV focus view, and your cursor is the lateral tricuspid annular plane. Lateral tricuspid annular plane. It's an M-mode measurement. So you're gonna look at the tricuspid annular plane. So it's gonna move in systole. It's gonna move up. It's gonna move up. So it's the excursion, is the distance that it moves up. Okay. So it's a vertical distance that the tricuspid annular plane. So remember that the tricuspid annular plane is going to move up towards the apex. So it's a vertical distance. And so this is the distance you want to measure. Okay. It is a systolic measurement. Okay. Anything less than 16 millimeters suggests RV systolic dysfunction. All right. So that's a very fairly accurate way to assess RV systolic dysfunction. The next method is your tissue Doppler derived S prime. So TAPSE is a linear measurement, it's a displacement, and then your S prime is a velocity. So not only the RV moves up supposed to move up at a certain distance, but it's supposed to have a certain speed. But because it's tissue and it moves relatively much slower than blood, you have to measure. You have to use your tissue Doppler. Okay, you have to use tissue Doppler to measure the velocity of the tricuspid annular plane. So tissue Doppler imaging, apical 4-chamber view, just the same. Okay, the Doppler sample volume is placed at the lateral tricuspid annulus. So just like you're doing TAPSE, everything is the same. Your cursor is placed at the lateral tricuspid annulus, but instead of pressing M mode, you're going to press your Doppler. Okay, you're going to press either your tissue Doppler or your P Doppler, and then get your tissue Doppler from the P Doppler. Remember, tissue Doppler is a form of P Doppler. So the S prime is the velocity. The S prime velocity is the highest systolic velocity. And so the number you have to remember is S prime less than 10 centimeter indicates RV systolic dysfunction. So less than 10 centimeters per second. Okay. So again, it's done just like you would do TAPSE, 4-chamber view, your sample volume, lateral annulus, where you press tissue Doppler. So you're going to get your systolic component, early diastolic, late diastolic. So this is what you're measuring. Anything less than 10 centimeters per second indicates RV systolic dysfunction. Okay? And very important. And then when you do your strain and strain rate, as you will go over this. All you need to remember now is that you can use strain and strain rate to evaluate RV systolic function, and it's probably the most accurate method. Strain is just a change in the length when the heart contracts, and then strain rate is a rate of change in that length. We're not going to go over that in any detail today, but just remember that. So we discussed the various methods to assess your RV systolic function, okay? And the methods that we discuss are RIMP. So we went over the definition of RIMP, fractional area change, tissue Doppler imaging of the tricuspid lateral annular systolic velocity, TAPSE, RV ejection fraction. We didn't go over that in detail, but you need a three-dimensional echo for that. And then the longitudinal strain and strain rate.